Thank you. It's great to be here amongst a lot of passionate people. What's the definition of passionate people in healthcare? You don't say no. You keep bugging the CEO. You never stop short of what you believe in. There's other terms they may call us, but it's certainly how you get across this big barrier of frustration that we're all experiencing. To Tim and Matthew, thanks again for letting me come here. I have to say I come in peace, although my obnoxious Tennessee football fans don't mean so well. So I was forced to wear a Tennessee smoky tie for at least 1 year. We have a win. I don't know about next year, but all good fun. I'm gonna try to tell a story that takes at least one little piece of that frustration away and shows hope and tries to bring hope back into the picture. It's an 8-year journey of something that wasn't just something that popped in my head, but it's a lot of curvy lines and odd things that led to it. And also kind of leave everybody with something I think is a challenge of how we get more of the frustration out of our way and a unique approach to trying to change the stigma and the story surrounding lung cancer. So most things in my life that have been meaningful have come from either my wife or my hound dog. And Highway 72 runs from Chattanooga essentially to Memphis. And it's a pathway that my wife gets to see her father. She goes there every week to eat lunch with him. It's a 4-hour drive each way, so 8 hours round trip. When I ask her why she does it, she goes, I don't know how much longer I'll get to do it. And you start talking about, as we've both aged, we see our parents aging, this fear of you're going to run out of time. You also get frustrated with the healthcare system that's not bringing the value you really want. I laugh at my primary care doctor because I go, you really didn't do anything. A chest x-ray on an asymptomatic guy, on the lung screening guy, you're going to order that on him, maybe? And you seek for such a better opportunity of how we can deliver value to healthcare. So if you've ever been in a 4-hour ride with my wife, the radio is stuck on the 70s channel. She lives in the 70s. She had the most amazing childhood and relates every song to the year it came out, what she was doing at a lake party, at somebody's birthday party, do a cheerleading routine, playing some athletic thing. Way more amazing in my childhood. But she also listens to the words and intents of the intent of the music, which I never did. And she always would tell me, you need to pay attention. So one of the things I thought would be good, I got an audiobook that really told the story behind what led the artist to putting those words on paper and putting music behind it. And there's 1980s was a great blues rock artist, Bonnie Raitt, that was around an influential time in my life. But again, I didn't pay attention to the words. I always thought about somebody fearful they weren't going to have kids before they got too old or wouldn't find the love of their life. My wife looks at me and goes, okay, go look up the video. It's exactly what we've just been talking about. So I got to where I could do that. And then there was this part, which is the second verse. So if you've grown up in the South and you've been around smokers, there's a stigma that if you smoke, you're gonna die of lung cancer. My dad was an amazing, brilliant thoracic surgeon, kind of came into that whole era of cardiac surgery exploding in the 1950s. Amazing career, number one in his medical school class, and he died in 1995 knowing that he was going to die of lung cancer, died of a heart attack. He also avoided healthcare because of it, but to his credit, I guess, or his rationale, they had 3 failed trials at screening attempts at chest x-rays. Everything that population believed, or his generation believed in, was there's just nothing you do about it. It's just an accepted fate. The problem is that's permeating a lot of our cultures around East Tennessee. It's just part of your bad card you drew in life, a social habit you did, and you're being punished for it. Imagine walking around with that, knowing that your life, you think about the end, when maybe it's really not. And a healthcare system that really wasn't trying to right the wrong and go to these communities and bring them some relief. So the end of this journey was something I did frequently. My father-in-law would take me to the liar's table at the coffee shop. And I'd sit there with people that I was told don't care about their health, don't want to live, can't engage in their health. And I would be bought a black coffee, a sausage biscuit. And I would sit there with these guys handing me papers of their lab work, a drug medication. Why am I taking this? This costs X number of dollars. I don't feel any different. What am I doing with this? And clearly what came to me was, we've got to change our healthcare delivery system. These people really want help. They're being told things that we perpetuate as physicians, that their life may be at risk. They feel like what Bonnie Raitt was singing about her father, John Raitt, who she had watched him sleeping one day and just struck her with his aging process and what time does any of us have left? And I go, there's a better way of doing this. But what I found is that same population, when I took my white coat off, I ate and broke bread with them and just talked simple terms, they engaged in their health. They would look forward to me coming back. So maybe we've been wrong on that aspect too, and there was a better way of doing it. So I really, on the way back home from that trip, said, my goal isn't focusing just on lung cancers. How do we increase our quality of life years? I want to live longer just like they do. I don't know what my mortality is. My dad wasn't, he died 8 years from my age right now. Crap, that's pretty short. And you start thinking of all these things, and I start getting mad at the healthcare system. So first step was, if I'm going to change the life expectancy of females, males, a certain group, and I got to know what everybody's dying from. And what kind of hit back at me is 60+% of our population is dying from a cardiovascular disease or cancer. And if you really narrow the cancer thing down, lung cancer is the biggest impact. Wait a minute, I got this tool, this lung screening, that's probably more powerful than just lung screening. I can start chipping away with it, and oops, the heart's attached to the lungs, so there's got to be some data from that I can start using to manage it. Maybe there's actually the first screening test in history that will not only decrease the mortality for that organ you're screening, actually make people live longer, engage in their health, maybe their quality of health. And it was just a conversation that was the 4 hours on the way back. So what do we do when we're frustrated, we're problem solvers? I went to our state data and looked at population, sort of a geospatial mapping of, if I'm going to target people who I think are the most at risk, where they live. And maybe it shouldn't have been surprising, but they live in the rural communities, well, certainly in Tennessee. And you look in those rural communities, there's a lack of imaging centers, with the exception of right in the middle part of our state. There's also a ton of rural hospitals that have closed. If I can't get somebody in Chattanooga or Nashville to go 10 minutes for a lung screening exam, how did I expect somebody that doesn't even know about it to drive an hour each way or an hour and a half each way? So I go to my wife, I feel like I'm putting together a puzzle, and I just dropped all the pieces out on the table, and I don't really know where things fit, but I know one of the corner pieces that's always easy to start with has to be mobile lung screening. I have to be able to take and go to the people, just like I was doing in Mississippi, who are thinking the same thing I'm thinking, who don't want to die, who want to live, and give them a better way of healthcare and educate them. And the gamble on that was, nobody ever built one. I go, surely somebody's done this before. And hospital was scared to death of this passionate surgeon or frustrating surgeon to them saying, let's do this, when they didn't know the financial stake in it. We didn't know if this was going to be a negative cash flow, what impacts it's going to have. We didn't know how to operate it. But I got people to believe in the concept and the idea that if it failed, we're going to trash it. At year 3, we'll do an evaluation, and certainly by year 5 was our end point. And the great thing is I've got the 5-year data to kind of tell you the end of the story of what this journey was. But how do you build a mobile bus that nobody's really built and can tell you even the cost of operating it? You go to Winnebago. It's only, pretty good branding. Forest City, Iowa. I was in Minnesota and been by the plant before. So we went and said, I want the biggest chassis you can give me and an empty shell. And then I'm going to drive it up to upstate New York, and we're going to put an old 16-slice CT scanner in it that we overly engineered to try to help alleviate some of the concerns from Siemens, who was our partner, that the machine may or may not hold up. It really hadn't been tested on Tennessee roads, which are treacherous. And in that, we delivered this product. We did everything wrong, but we did it based on what we know. So I know what an imaging center looks like. I know what it looks like in our hospital. Let's just reproduce that, except it's inefficient. People can't get in and out. We were looking at the throughput of, we have a CT tech that had our own station. You put the patient in there as if they're going through some terrible test, and I'm going to run and shut the door, and then I'm going to pull the trigger on the test. Well, that's psychologically terrible. We have technology. You can stand right there with the patient and the machine, and also will increase the throughput. The screening is a numbers game. We got to make this something that we can do higher volumes. But this is what we start out with. The financial results for public took 2018 data, because that's really what most of the stakeholders wanted to look at. Is this a viable solution? Is it economically viable? And we did a pro forma out for 5 years. We published it in Annals of Thoracic Surgery, which was, in the beginning, they're like, I'm not sure this fits in here. We presented a meeting and there was a lot of discussion. The good thing, like most of what we're all seeing here, the frustrations of that, was it came around to actually it does belong, and we're going to highlight it as the article of the month. One of the key findings that we found in that study was, not surprisingly, majority of the patients, non-pulmonary, 66% had severe coronary artery disease. At this point, we're just doing none, mild, moderate, or severe. Now we've got the ability to do calcium scoring and get a little more sophisticated. But it started opening my eye up into lung screenings more than lung screening. This is I think will be the biggest opportunity to change a disease in a population in our lives. And we're all sitting here on the forefront of it with pairing AI and a relatively simple, reproducible scan that has so much value that we've been ignoring. So they highlight the article. I couldn't get, prior to this date, anybody to talk to me, much less the CEO, she'd run from me, about lung screening. And yet 250 TV stations picked it up. Okay. All the internet news sites started picking it up. Got a call from the White House. Okay, never gotten a call from the White House before. And I've done things that I thought were much more significant. All of our local news media, but they build it as not lung screening. They build it as the easiest doctor visit ever. So maybe we've been packaging things wrong. We haven't been given the value to healthcare. We've been saying, if you're a bad person, you got to get on the bus and get this test. If you're a good person, you don't get the test. Maybe that's part of our own fault where we've created the same frustration. So I started leaning on the news media and people that are better at selling something than I was, is taking that stigma away from it and engaging in the value of it. So what did we learn from that experience? The mobile bus was built wrong. The chassis at year 3 was fractured, not drivable. We wanted to keep it. The Department of Transportation said, you got to take this off the road. But it could handle a 27,000 pound load, and we drove it with 26,999 pounds on it. So not surprising. Terrible engineering design. My Vanderbilt engineering degree did not pay off. So the other thing was the throughput. We struggled with going to a site and getting the numbers we needed to scan. So there's a lot of different opportunities. From a different picture up here. I think we're back. Okay. So the other thing is we went too far. Everybody called us all over the state. We would drive 3 hours. That's crazy. What am I going to do with somebody that I find cancer in, or a significant finding that's 3 hours away from our hospital, if I hadn't set up networks or partnerships? So the other thing is we learned we have to be able to get in touch with them. We have to have a way of communicating with them that's reliable, and we got to stay within about an hour-and-a-half range, or have a partnership with another hospital. And the last thing was the finances and the cash flow were actually extremely favorable And I call it good profit. There's things you can make money on that you're not helping anybody. This was one of the things that the patient won, the hospital won. Everybody involved in the project came out a winner, which I've never seen in business or in healthcare. So we went back to the drawing board, which was part of our idea, take the prototype, learn our lessons, and we redesigned it, went to a chassis that was 52,000 pounds instead of 27, dual axle, multiple doors so you can go in and out, better throughput. And this was the final version of it. It also had needed to last 10 years. It had to be easily serviceable. So the commercial HVAC system we put on it had to be easy for the maintenance people to get to, the generator, all the components. You have an opportunity of strategically putting things, knowing what routine maintenance and stuff. It needs to stay on the road, not in the garage or the shop. So this is Chattanooga. Chattanooga, as you can see, lots of geographical barriers, bridges, mountains, lakes, rivers. When you get about 20 minutes outside of the city, you get into the real rural and sometimes mountainous roads. The idea is that we've learned, we get everybody pre-registered. So we do a lot of work before we ever show up to the site. The patient shows up already registered. They'll come in one door. We'll confirm with Epic. The bus is connected to the hospital through right now through cell towers and confirm they are. We also get them to sign a HIPAA compliant text messaging service. We've got everybody's cell phone number as how we're going to communicate with them. They go in and get the scan. The tech stays in the same room with the patient, and then the patient leaves out the other door. So you've got one person in the car waiting as your up to bat, kind of your waiting room. You have one person confirming the registration. It's already been done. You got a person on the scanner. The tech sends the images straight back to the hospital. So in 15 minutes, the radiologist is getting that scan. So they don't have to read a whole dump of files at the end of the day. But also 2 hours later, I can give the result back to that patient with text messaging and link them to my chart. Imagine an 8-minute visit to these people who have had terrible experience with healthcare, to a scan they now see is not a punishment for lung cancer, but look at the heart, everything else, and they get the results the same day. And for the things like smoking cessation, or for they got coronary artery disease or osteoporosis or other things, their COPD, you have ways of communicating with them, but also the way to get them back in the next year, which was one of our challenges when we looked at this. How do you get them back in for their next year? So along came COVID, which was actually a good thing for this. We never stopped lung screening during COVID. I think we're probably one of the only places because we had a safe place for people to scan. They could stay in their car, you could sterilize it in between, you could clean things. We felt it was too important that we shouldn't stop. Telehealth became much more acceptable, so it allowed us to communicate back and forth. We now only have a driver, the CT tech, and a registrar person on the bus. If somebody wants to walk up and get scanned, we never turn anybody away. They just communicate back through telehealth and office, and we do all the paperwork and then get them in line as soon as there's a break. AI started coming around, which was really, I think, one of our biggest assets to this area, and particularly in all of radiology. You start seeing the ability to improve our workflow instead of having to manually do the coronary calcium scores or look at all this other data that taxes or slows down the process. You had innovative software techniques that were helping you. We started now reporting coronary calcium scores. You can look at bone density. You can do your aortic screening. Probably the HIPAA compliant texting was the cheapest and simplest and most effective thing we implemented. And getting the same day results was a goal of just beat the patient's expectations. It's already so low, but if I can beat it, then maybe they will be surprised about healthcare for once and engage. You look at from a low-dose CT scan things that you can get from multiple different vendors with the AI piece, and you can certainly get a picture. When I'm first going to an event, I will go there and I will sit there with the people get screened and go through their scan with them. So the scan's sent back to the radiologist. I'm looking at it through my laptop and through our PAC system and sitting there with the patient. I'll go through 5 or 10 minutes and just show them pictures like this. Once you get them to buy in how bad their emphysema is, you quantitate it, you tell them their risk. Emphysema, COPD, it's in that top 10 list of things that people are going to die from. If there's a nodule, you can show them. You can look at their bone density. All these other things that come from the scan, other than just you have lung cancer or don't have lung cancer, became really a changing point of how they viewed the test. And there's so much. One of the things I was reading on the way down here, one of the companies has looked at validating fatty infiltration of muscle off the CT scan as a predictor for dementia. My mom died this year of dementia. Normal labs, normal mammography, normal colonoscopy, no coronary disease, did all her routine physical exams. Oops, we forgot the dementia piece, but we don't know how to pick it up. Now we're seeing off these same scans, a true and true. We don't know exactly the relationship, but you're seeing things that you can start chipping away at that whole thing we want, a little more time and a better quality life. So what was our test model? Spring City, Tennessee. Spring City, why I picked it was it had one primary care physician who's a pediatrician, the coroner, the adult family doc, helped at school, substitute teacher. She really was the Doc Hollywood of this town. But she was asking for help. Their population was on a map, was one of the centers where high prevalence of lung cancer, high mortality rate, and it was a controlled environment that I said in 5 years, I think we can change that. Our frustration, their negativity about it, and create a culture that hopefully shows that all this can occur. So this was the first bus in 2018, the prototype. We engaged the primary care physician, celebrated her willingness to do it, provided lots of resources. The first day we were up there, we scanned 2 people. Fast forwarding 5 years later, this is Spring City. It's truly a stoplight town. I got a call from the primary care doc that said, "You don't know what you've done." And I go, "Okay, let me have it," because healthcare, we know this phone calls. She goes, "You've changed this city. You've changed this town." I go, "What do you mean?" She goes, "We have 12 people with lung cancer in a population of 2,400 that are alive, going to work, going to church, integrating with the community." Goes, "That didn't happen in this community." And now those people are educating the other people in the town to go get lung screening. If you look at from day one where we had 2 people show up, we just show up with the bus. They fill the spots out. We now can screen in one day, get there and get back about 42 people and get one every 8 minutes. So we have 42 on the list to be scanned in this town that's now extending out into the region, but it's not me trying to sell it to them. It's the people in the community that finally realize there's something of value, there's hope, and you have those cancer patients who benefited from it become your advocates and sell the story, which is much more powerful than me. One of the best things that came from it is for those who told us they won't come back, you can't get them back in. We've all struggled with annual follow-up rates. We have a 76% annual compliance rate, which is not what it is in Chattanooga. But the key is if we can get them engaged, if we can get the buy-in, and it's a 5-year journey. You're not going to see it in 1 year, then you truly can change this around. But now how do we multiply it? How do we go to other places like this? It's not for everybody, but there's similar geographical communities, barriers to access that if we invest the time, it's hard work, but we'll get there. So what do we see? We can easily reach the most vulnerable. We can target data-wise who's most at risk. The bus model is reliable. It's just how can we get them built? How can we get the industry and the supply chain to help expedite the process? But to our governor, I said, in the state of Tennessee, almost half of our population will die of lung cancer or heart disease. What if I cut that by 1/3? What does that do to our state economics, the stability of our workforce? And he looks at me and goes, "I don't know that you can, but that would be amazing, from every stakeholder involved." I think that's really the opportunity on the table. I think you can also improve someone's quality of life, looking at their core muscles, you can pick up on diabetes, other health-related issues, osteoporosis. I do think we'll get to maybe the first screening test that actually improves the overall survival of that population. So last I'm gonna leave with, all of us are incredibly frustrated. And again, my best ideas have come from my wife and my hound dog. And in one of those journeys to Mississippi, she goes, you got to quit spending time with your colleagues who are set in data and facts that are outdated. They're stubborn. We're difficult creatures to change. Go pick on a different model. Go educate the young people. And you got to do something that gives you permission to talk about it. You got to make it fun. You have to bring some positivity to this whole field. that helps you get out of this whole frustration. She goes, you need socks. I go, I have socks. She goes, no, you need these socks. So she had she's in the clothing business. So she had a manufacturer make socks of all different colors with the lung cancer written on it. And purposefully, I'll wear my high water pants. I'll put obnoxious colors, and it never fails, whether I'm standing out in front of a hotel or I'm in an airplane. What is that? And it allows me now the permission to tell and educate about it. So we took that idea into our local high school, and we did a month-long project showing the science behind lung cancer, educating the truth of what we know today, not what my dad knew. And then let them go home, tell their parents, their grandparents what they're doing, get them stimulated. And we bought 1,000 pairs of socks and put them on all the kids and said, take fun pictures, go put it on the Instagram, go to make a reel and make this something that is fun. It's not scary. It's not frightening. And they didn't know any better. And they did. And they got incredibly creative, much more so than I would have. And what it's led to now is we take the mobile bus to that high school periodically, and when the parents drop their kids off, they're getting lung screenings at the school. So to all of us who say this, we're all frustrated, hell yeah, we are. But that's every business, every startup, every development, whatever you're working on. But there's pathways we can knock this out. So our kind of idea, our hope is that we can have sort of a national socket to lung cancer day. So we need partners with industry. We need people in the film and movie industry. We need musicians. We need sports figures. I've got a long list, but we're talking we need millions that really are putting this out. And the most opportunistic group are the young people that aren't set in their ways. They don't know what they should know about lung cancer. They haven't been taught something wrong. And they're incredibly good at getting the message out and to their parents and their grandparents better than anybody else is. But this is a thing, you know, you don't have to buy the socks from us. If people do, it goes to our lung cancer advocacy and support group, a nonprofit. But we had people making their own socks. You have women's socks. You have teenagers don't want to wear the same socks I would wear. You have older men that want the classic socks. The reality is I think you can make this fun. I think we can change the frustration into hope. But we've got to start doing things that are different than just preaching to the people who are really set in their ways. They'll come around, but we need the younger generation to do it. I think everybody in here can help us on this. I think we'll be sitting here someday, 10 or 20 years from now going, holy cow, that was the most amazing period in healthcare of bringing value back to it. And we sat at the Grand Hyatt in Florida and we're in the ground floor of this process. And what a cool spot to be in healthcare. So I'm gonna stop there, and I appreciate you letting me tell our story, and hopefully there's gonna be more stories coming from other people that can easily do the same thing. Thank you.